hi everybody out there in the Facebook land. I'm Dr. Lawrence Handler, along with my partner and friend, Dr. Zachary Pierce. We're going to be discussing upper eyelid surgery, very informal. I'll let everybody know this is my first time on a Facebook Live event. I don't know about you, Dr. Pierce, but
yes.
So I'm a little intimidated. The questions, I have a good grasp of all the material, but the whole Facebook Live and presentation is a little new to me. So hopefully in the future we'll do a lot more and we'll be really, really good at it. So
yeah.
Hopefully. But my name's Dr. Lawrence Handler, and Dr. Pierce and I are at Michigan Oculofacial Specialists. Sylvia is in the background. She's going to be helping us. She may be asking us questions where you can't hear her, so we'll repeat the questions. So I think I've introduced this enough. I'm going to hand it over to Dr. Pierce to do a little bit more introduction.
So Dr. Handler and I are what is called an oculoplastic surgeon. So we trained in eye surgery and then subsequently in plastic surgery, focusing around the eyes and face. So that makes us particularly adept at the information that we're going to present to you today and just interact with you. We really focus most of our practice on doing eyelid surgery, and upper eyelid surgery is by far the most common thing that we take care of. We have 3 locations. One is in Clinton Township, another is in Troy, Michigan, and the other is in Farmington Hills. And we each see patients at each location, and there are multiple surgical sites around town that we operate at.
That's why I'm not used to being with them today. It's so unusual that we're together. So I welcome the opportunity to be able to spend a few minutes. Yeah, you too.
Our information, phone numbers, website addresses, those are found on the Facebook page. An easy way to remember our practice website is myeyelidexpert.com. That's a great way to interact with us online outside of Facebook, and can make appointments and contact us through that.
That sounds good. We ready for a question to kick it off?
Sure.
You're good? Okay.
Yeah.
When we talk about upper eyelid surgery, there's the cosmetic aspect of some patient populations, and there's the functional aspect. And on some patients, there's a mixture of skin excess and the lid height itself. So I'm going to have Dr. Pierce explain to us the difference between a blepharoplasty and a ptosis surgery, or both. Go ahead.
So this is one of the most important things to understand when you're undergoing upper eyelid surgery, is recognizing that there are multiple factors at play. And so part of our job here is to educate you so you can help make informed decisions. Dermatochalasis refers to redundant skin. It comes from the Greek meaning skin and loose, so loose skin, and it progresses to the point that the skin can cover the eyelashes and weigh things down, creating kind of a shadow effect. Dermatochalasis is treated with a surgery called a blepharoplasty, where we remove a safe amount of excess skin and shape that so it looks good. Ptosis, on the other hand, refers to a droopy muscle. Sometimes the muscle is weak, sometimes it just gets stretched over time, but it allows the eyelid itself to fall where the edge of the eyelid is down over part of the pupil. Sometimes that can affect the vision as well. This is a similar but a slightly different surgery that we use to correct that we call a ptosis repair. And you can see how in this patient, once the eyelid is tightened or elevated, it lifts the eyelid where now we can see the pupil. This is really fundamental to understand, as you're undergoing a consultation and recognizing, hey, what do I need? And the nice thing about seeing us is that we can customize the treatment for you and recognize that this is not necessarily a cookie cutter procedure. Everybody's unique. On the upper picture, we can see excess skin. The lower picture has a droopy muscle. Dermatochalasis is the upper picture and ptosis is the lower. When those are corrected surgically, we can see we end up with a nice shape. We're clearing the pupil and getting that extra weight off of the eyelids.
You know, I'm gonna interject a little bit on the ptosis part, because I think people come in with a perception that there has to be an ideal height regarding the lid, and we're talking about the lash line. That's what we're talking about, lid height.
Mm-hmm.
And I've come over the years to realize that is very customizable depending on the patient. So I happen to look at photos from 10 to 20 years ago to get an idea of where that lid height was, and pretty much want to duplicate that lid height. People who've had a lower lid height for years, if that lid was elevated significantly, they might look thyroidal. And maybe the opposite, somebody who had a more prominent look, if it was dropped too much, might look not like themselves either. Mm-hmm. So I'm just throwing that in the mix, that when you look at these photos, don't take that I need to be at a certain height,
right,
or someone needs to be at a certain height. Like you said, it's a discussion that you have to have with people in an office setting to kind of have an idea of what the goal is before you go into surgery.
Yeah, great point. And sometimes it's not as clear that patient just needs one. Sometimes patients will need both procedures. And you can see in these examples, the patient had extra skin, but also a low eyelid height. And so they really needed both of those surgeries to correct that. Sometimes, I don't know about you, but sometimes I will do these surgeries together. Mm-hmm. Sometimes I recommend doing one at a time and kind of watching the healing process, and again, discussing it with the patient, what their goals are. Do you have any comments about that?
Well, and sometimes it is a question of whether it's cosmetic or functional. People come in all the time, and is this going to be paid by my insurance? Is it not? And so, like you said, sometimes these procedures are not necessarily done at the same time because of that, because of other factors. So, I guess we could jump into where somebody would be eligible for insurance coverage or not. I don't know if I'm out of order again.
No.
This is our first time doing this Facebook stuff. So,
yeah.
But anyways, maybe that should be another discussion here, is how would someone be eligible for insurance coverage on something like this?
So there's really 4 criteria for a patient to be covered. There's the patient's concerns or observations that it bothers their vision. There's certain measurements that we take in the office. There's a whole series of photographs that gets reviewed by the insurance company. And lastly is a test of your side vision. Do you want to comment what that is like and for a patient?
Yeah, well, first of all, I know Zach's doing the same thing. Should I be calling you Zach on this, or Dr. Pierce? I'm not sure. I guess is Facebook that informal? We'll call you. All right. Yeah. We can't just make up that someone has functional insurance-based findings.
Right.
So clearly somebody has to have demonstrable problems in their everyday life. That's the first step. Mm-hmm. And then when you go through these testing, I know you're not going to do this. I don't do this either. I'm not putting somebody through any sort of testing, even as minor as it is, to waste their time if I already know it's not insurance based.
Right. If it meets 3 out of 4,
right,
it's not going to meet. So why put you through that testing?
That's a good point. Good point. So you were asking me about the peripheral vision. There's peripheral vision testing that has to be done. It's on a specific machinery, a visual field machine, and lights are projected, and you have to demonstrate that you're seeing lights or not seeing lights. And then on each eye, it's done separately, and then taping is done to then do it again to demonstrate if there's a significant improvement, simulating if the surgery was done, what the result would be in regards to peripheral vision improvement. Mm-hmm. So again, each insurance has their own criteria for that, so this discussion is not going to get into that. Given the audience, we don't know what your insurance coverage is. So that's the kind of testing. In our office, we would also do photographs. We would do tear testing to see if someone has a dry eye or what's going on with the ocular surface. Again, that's, I think, an advantage of coming to us, that we have that sensitivity of the eye and the eye area. So we would try to sort that out. Patients who have significant dry eye and really are symptomatic, that sends a red flag up for me, and I might, if not probably not treat them myself. I might call in or ask for other consultations from my ocular, ophthalmic, optometric colleagues to kind of get a handle on it. Interestingly enough, and I don't want to go too far in the question.
Yeah.
I don't want to take the whole time on one question, but in terms of dry eye, I find that people are using their brows a lot, so the eyes are open. Their blink mechanism is not normal because they're elevating their brows. These are functional patients. These are not cosmetic patients I'm talking about. And the dry eye actually can be worse because of excess evaporation, and it creates ocular symptoms where when you correct it surgically, many times that helps. Where we've always been taught that if you start doing ptosis correction or blepharoplasty, you can make a dry eye worse. And I'm not saying that that can't happen, but there is a patient population where they're symptomatic and they don't get worse, but they might even get a little bit better. So again, each individual is unique and has to be, a consult has to be done to sort that out.
Yeah.
We have a question from Michael. If your lids are asymmetrical prior to surgery, can symmetry be achieved by surgery?
So that's a great question. Thank you for interacting. The question was about if my eyelids are asymmetric beforehand, how is that addressed in surgery, and is it possible to make them more symmetric? And that certainly is our goal. Our aim is to make things even, make them match, and we accomplish that through a few different ways. And I think it starts with the consultation in the office, where we can really try to evaluate the function of the muscle, really try to determine the underlying cause. Is it ptosis, dermatochalasis, really what's at play? Looking for evidence of any weakness or nerve damage that may give a suboptimal response just by lifting the eyelid. At the time of surgery, we do everything we can to make things match, and sometimes patients get nervous about this, but I assure you that most patients do really well. But at the end of a surgery, sometimes we'll turn off any relaxing medicine so you can wake up at the end and we can really just fine-tune things and make sure that they match. That really gives us our best chance of making things where we want. The other thing I will always warn people is afterwards, don't pay too much attention to the symmetry right after. Sometimes with swelling, with the healing process, sometimes it can look a little uneven, and oftentimes it will take time for that to balance out. But any other comments on that?
Look, we can go through a mall, you and I, and see people and pick out things very quickly and know why we're picking them out as far as asymmetry. The general public, are picking out asymmetry without realizing it. You don't analyze it quite like that. So symmetry is key. And so when I talked about lid heights before, I would rather have a symmetric lid height than a particular lid height. So maybe on a particular patient, I wanted to get that eyelid 4 millimeters above the pupil or 5 millimeters, but I achieved 3 or 3.5. If it's symmetrical, that patient's going to look great. If I achieve one lid at 4 and one lid at 2.5 or 3 millimeters above the pupil, you won't realize it, but your brain will detect that that person has some asymmetry. And that's how people judge it. And I do want to say this, that whether something's done under insurance for functional reasons or cosmetic, the goals are the same. I don't look at people differently. I want symmetry. I want it to look great. And of course I want people to be happy. And so I identify a lot of this stuff ahead of time. I look at photos 10 to 20 years ago with a patient in a room and point out the asymmetries, because some of the asymmetries are not correctable. They're from other things. Maybe your brows, maybe there was an accident, maybe there was a condition. People have had zoster or other things around the face, skin cancers. So we want to look at it ahead of time to make sure that the patient understands what are we capable of doing, what are we trying to do, what are we trying to do with that particular procedure, or do they need other types of procedures in addition to the eyelid surgery?
Yeah.
So I think it's something that after listening to us for the half hour, you may think about that during the course of your day-to-day, and as you spot people, you'll know, your brain will pick up asymmetries, symmetries, but you'll realize you don't realize that you're doing it, but you are doing it.
Okay. Michelle
Yep.
asked a two-part question. If you have excess skin in your lids and significant bags below the lower lash line, will insurance only cover the upper? And the other part is, can you fix the lower as well?
Okay, so Sylvia is, can everybody hear Sylvia? I guess not. We're talking about upper eyelid and what's coverable, and if lower eyelid surgery can be done at the same time. I believe that's what it was, bags of the lower eyelid. And of course, we intermix these surgeries all the time, and people come in, patients come in on consults, and they're pointing out the upper lids. And again, this does not matter whether they're coming in a functional category, meaning that they need to do the procedure for actual vision purposes, or aesthetic or cosmetic. A lot of people have concerns about those lower eyelids, and virtually 100% the lower eyelids are not covered from a cosmetic standpoint. Insurance generally does not. I can't remember an insurance that covered a cosmetic procedure. Early in my career, believe it or not, there were patients under some insurances that covered cosmetic procedures. I think that day's over.
Yeah, I agree.
But do you have some more slides? I mean, I think it's time to get off us and maybe back on the slides. That might be nice. So yeah, do you have what slides do you want to show us next?
When I was talking to people that we were going to do this, some of the questions I kept getting asked over and over again is, well, what's the recovery like? What do I expect afterwards? And
this is a good one for upper eyelid surgery.
For upper eyelid surgery. So let's see what we got here.
Yeah, thanks for the nice setup too, Zach. You got this thing looking great.
So for the first week, and these are just a random splattering of some patients at about one week, so you can see the variety of colorful bruising and swelling that people can get. Typically, things are softly swollen and bruised, not painful, and you can still see, but you look a little beat up. We usually recommend doing a lot of cold packs or ice packs those first couple of days, as the swelling usually peaks around that second day and then starts to slowly go down. We often recommend doing a lot of lubricating eye drops or ointments to help keep the eyes comfortable, because they're going to be more open to the air, can feel a little dry and irritated. And then sometimes we'll use Vaseline or an ointment to the stitches.
So I'm going to interject. As chefs do all the time. You're a wonderful chef. I'm a wonderful chef in our medical practices. My routine is different, you know. So I think you're going to get, if you come to Dr. Pierce, you're going to get one set of instructions, and if you come to Dr. Handler, you're going to get another set of instructions. And I tell patients all the time that over the years I've changed my instructions, and just like a chef might change a recipe or something like that, it's an ongoing process.
Right.
And so mine have developed over the period of years. Yours has too, and so there's differences.
Yeah.
I don't know if we want to get into those at this point, but I agree with how you're presenting this, that there's going to be probably some bruising and swelling the first few days. Everybody's a little different. We really work hard at analyzing people's anticoagulant status. So people who are on Eliquis, Coumadin, etc., Xarelto. These are the big ones that we see. That's a big thing. We got to step back and look at it and find out if we can get cardiac clearances or internal medicine clearances on some of these products, because that can complicate things. And at least lately in my practice, we've used some other things in the local anesthetics to try and decrease some of that. And then some patients will do the home remedy arnica. I don't know if you're a big arnica person.
Yeah, I think the studies are a little equivocal. Some say it helps, some say it doesn't. And so I have no problem with a patient using it, but don't consistently recommend that as part of the routine.
That's interesting, and I didn't know that of Dr. Pierce, but same thing for me. I tend to want to get people off of all the vitamins and aspirins and nonsteroidals, and so I felt the same way, because once you start making exceptions and take this and don't take this, it gets very confusing. We're doing this all day. The person having it done probably never had it done.
Yeah.
And I like to be very clear. No, 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 no. And then after surgery, a few days, yes, 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 yes. But I don't want to start this one's okay, that one's, I used to say, it's fine to do these vitamins, but not these vitamins. You know, it's too confusing.
Yeah, and you don't always know what's in all the vitamins because
Exactly.
there's like, you know, multiple things in there.
Right.
So.
Right,
Chair, just-
I agree, okay. I'm sorry, you were in the middle of a nice presentation.
Well,
I
that's
interrupted
okay.
you.
I do always warn people that first week, if they're significantly painful, if they're swollen totally shut, that's
Mhm.
more than I've
Yeah, yeah.
described, and you
Good
know,
point.
I want a phone call.
Definitely.
If stitches pop open, you know, something like that. This is surgery. The vast majority of patients do great.
Mhm.
I mean, without a doubt. But it's surgery, so I always leave that line of communication open. If there's a concern or a question, just call. Not a big deal. That first week, I do think it's important to really take it easy, avoiding anything real strenuous or heavy lifting or anything like that. Most people are taking 1 week off of work in most situations. But still, it's okay to see. You can read, you can drive, you can get around. Showering, you know, shortly after the procedure is typically fine. Then that second week, we'd see you back in the office to get the stitches out. You're increasing activity, kind of getting back to normal life. And then for me, usually by the end of the second week or the third week, it's kind of life as usual. You still look a little beat up in some cases, but feeling well, and usually no restrictions at that point. Once we get about a month after surgery, we're looking pretty good, where patients aren't really going to be noticed if they're in the store, but there may be
Right.
some redness along the incision or some areas that's still a little swollen, and that just looks better and better and better over time. If there is a little asymmetry afterwards, oftentimes that will just totally balance out over time. And I think looking natural, looking like they look, you know, those are our main goals. The whole healing process is somewhere a 3 to 6 month kind of course, I think, for most patients. And you can see the incision lines, even at just a month or two, look good. They're a little red, and those will continue to fade and blend. And I think patients usually do great with this
I
type of
mean,
surgery.
I tell people, you know, probably after 2 weeks, you know, on the women, it can actually be a little quicker because they can use makeups and things like that pretty quick. If they're doing upper eyelid surgery, I tell them to go ahead with the lower lid cosmetics immediately. On the upper eyelids, I may ask them to wait 10 to 14 days. And so with cosmetics, we're not going to see a lot of the subtleties, you know, as long as there's symmetry. They're not, the outside public, people who aren't aware of the surgery, are not going to detect that kind of thing, even though the person who's had the surgery is going to detect minor
Right.
little swelling that still has to come down, or numbness. When they go to apply makeup, they'll have a numbness along the lash line for a while.
Yeah, that's common to hear.
But really, you're talking, if someone has a major event, I ask them to do it a month ahead of time. You know, to plan for a larger audience where some people have a longer recovery and some people have a shorter recovery. I don't want to I'll err on the side of that. But usually I tell them a month, but you know, pretty much after about 2 weeks, they can get it back.
Okay.
Same with exercising too, about 10 days for me.
Yeah.
Any other questions, Sylvia? And here I was going to do a shout out to my sister in New York City. She didn't send a question in. I'm gonna talk to her about this. What about my wife? She didn't send a question in either. Okay.
There were a couple questions
That's true, yeah,
that folks asked beforehand, before the event, and
Yeah, I like this one. The question was, is it permanent? Is the surgery permanent? You want to tackle that one?
Well, my line is, this doesn't stop the aging process.
True.
And so over time, you will get, you know, continued aging. And so to have it repeated is not uncommon,
Yeah.
but typically it's about 10, 15 or more years, and it never seems to get as bad as that first time. What's been your experience? You've got a few years on me.
Yeah, Zach, I have a few years on you. True. So I'm actually seeing some of the repeat patients,
Yeah.
but you know, that's why I ask them to give me photos from 10 to 15, you know, sometimes 10 to 20 years, because that's kind of the reflection. The clock will start ticking again the day after surgery.
Yeah.
Other things happen again, you know, various conditions and aging conditions and medical conditions. So yeah, nothing's permanent, you know. Getting my hair done's not permanent, you know.
Yeah.
Getting anything done's not permanent. But so yeah, people understand that. I think the other question could be, well, if I've had facelift, eyes, forehead done, can I have this done again? And we do see a population that is coming through where there's been prior surgery, and there's some challenges that can happen with that. Again, some are not challenged. There's not a lot of challenge, and others are. And again, this is where this type of presentation we're trying to be in general terms, but it comes down to an office setting and a discussion.
Right.
But I think the old photos for me are very good, and patients love that. People come in, they like seeing the old photo and the new, and they like seeing their photos that were taken before the surgery. And we have fun with it. It's nice to see.
It is interesting to see those pictures. And you can see someone that has a full upper eyelid that looks youthful, and other patients, the same looking eyelid would make them look older or interfere with their vision. So it is really interesting.
And look at all the celebrities that have had various eyelid characteristics where they're disrupted, and people are in magazines and they're making a big deal about it. I mean, I can't tell you, patients will say all the time, I don't want to look like X, or I don't want to say the celebrity, or but in private they'll say I don't want to look like this one or that one, and I get what they're saying, and it comes up all the time. I think a quick explanation on that: the natural eyelid crease. So if you lift the skin up and you look at the line that most people have, if it's generally a little bit lower, more toward the lash line, you're going to have a more full lid as a young adult. And if it's the opposite, you'll have a higher lid platform and a more noticeable lid platform. And this is exactly why photos are needed, because you have to look at that, and you don't want to. And I guess in our community, I don't hear a lot of people saying, I want to be changed 180 degrees from what they were. Now, if you're in other communities of the country, you could be into that. And so some of the surgery is tailored toward the local community that you're in. So that's another reason for a consultation and a discussion, because you better be sure of what the goals are, and I need to be sure of what the goals are for the patient, and the patient has to understand my thinking on it too. And if we don't match, there are patients where you say, you know what, thank you, I'm not the guy. I'm not your guy. Yeah. And you have to be willing to do that. Sylvia, are you wrapping it?
Nope, I've got more questions.
More questions. I'm having a great time. Okay.
How far are you booking for a new patient? Denise wants to know.
I couldn't say. This time of the year it's very busy, because patients who have insurance and benefits, it goes both ways. Some even the cosmetic benefits can be used on some company benefit line, I guess flexible spending. So it's a free-for-all right now for this time of year, but there's people. It's an elective practice for the most part. I mean, we do a lot of other emergency things, but in this regard, these are elective type procedures, and so there's always room,
Okay. I would like to get the keloids question. I have keloids. Am I a candidate if someone has keloids?
Okay. Yeah. There's a difference between keloid and a hypertrophic scar, and these are maybe beyond this type of format, but I do not see a keloid on a lid. You'll see a hypertrophic scar. So I think what the person is saying is that they've had other surgeries in their abdomen or elsewhere in their body, and they have a keloid history, but you don't see a keloid on the actual eyelid itself.
Right. Yeah, I think histopathologically, there's a difference between the two, and they just don't see those on the eyelid.
Right.
That's not to say that a prominent scar could not develop. I think using the more modern techniques that we're using, it's much less.
It's not an issue.
And really monitoring things. Some patients we will recommend some other treatments just to encourage things to flatten out and blend, but typically the scarring is really minimal.
It is. I mean, at least in my practice, first post-op, whether if you're using stitches that come out or not, that can be a difference on different patients. Let's say we're taking out a stitch, and then I might start them out on a little topical silicone, or get them back on their moisturizers or some sort of moisturizing product, and then sun protection too. Sylvia's, are we wrapping it up? People are getting bored or
Go
what?
ahead, give us your take-home messages.
Well, the take-home message is that obviously, I guess we needed more time to cover the topic, so there's more to it than just come in and have eyelid surgery, but a consultation is definitely needed, and all the things that you've heard this morning. But it's nice that we could do this, and I'm enjoying the format and how this is done, so I hope that we can do more of this and interact with the public this way.
I mean, you can tell that we both love what we do, and we take it, very seriously, give everything a lot of consideration, and really want to help patients reach their goals, help maximize their vision and look their best, and having that perspective of an eye surgeon initially really, I think, gives us a unique perspective, and it's fun to get to interact with you and kind of hear
we're gonna do more.
similarities and differences.
Yes.
And
we're going to do more of this
I've
for sure.
enjoyed it.
Yeah, I mean, we're going to do more of this. It's we enjoy, for this type of elective work, very satisfied patient populations, and it feeds on itself. And it's not to say that you might have to do little corrections or tiny things in the office. For the most part, most patients do great, and they're happy, and it puts a smile on my face to see that, certainly. So I guess Sylvia wants us to wrap it up. So you said you've got the website and phone numbers somewhere posted. I don't think I need to say that. If there's one more question, my sister didn't come in with that question yet. Okay.
I thought it was a great presentation. Lots of
Well, Sylvia, you're so kind. You're so kind. Thank you.
Thank you.
Is it Dr. Pierce, Zach? It's great being with you today.
It's been a pleasure.
Yeah.
So,
all right, good.
all right. Thank you so much. Look forward to seeing you in the office.